Thank you very much, Joe. And thanks to Haresh and Jay for inviting me to Hot Topics. It's wonderful to be here. So let's see if I can drive this right. Regarding disclosures, I am the president of Vermont Oxford Network. I'll be discussing some of our data, and I am the coordinator of Cochrane Neonatal, and again, we'll be presenting some of those results. I'd like to start with this very simple figure from some work by Paul Batalden that talked about evidence-based medicine, but I think reminds us that beyond evidence-based medicine, it's how we practice and what we choose to incorporate in our practice that ultimately will matter to our outcomes. And so evidence-based medicine is the do what. And I hope that we're all pretty familiar with how to get to that answer. But the do how clearly is very different amongst all of our centers, and I'd like to explore some of those cases. Here's an example of some practices which have a fair evidence base. And if we take a look at a very restricted population, infants 27 to 29 weeks gestation, a population that I think we would all agree we're doing everything available to lead to the best outcome, you still see a great deal of variation in our practice. Here is work from the Vermont Oxford Network involving over 22,000 infants. And you can see that when we look at a well-accepted practice of antenatal steroids, that 25% of our centers are giving it to 80% or fewer of the babies 27 to 29 weeks gestation, and 97% of our hospitals 25% of our hospitals are giving it to 97% or more of this population. If we move down to some other, perhaps more controversial issues, when it comes to getting CPAP delivered in the delivery room, we see that at 25% of the hospitals, 40% or fewer infants are stabilized on CPAP, but at 25% of the hospitals, 80% or more infants are stabilized on CPAP. So then the question comes that if we actually are reading all of the same evidence, why is our playbook so different? What leads to that variation? And this morning I'd like to touch upon areas where I think some of that variation is healthy and expected and necessary, and areas where that variation is probably problematic. Let's start with a couple of rules, though. It's not too much math in this, but this is a wonderful review article by Kent and colleagues, looking at the limitations of when we try to apply the summary results of the evidence to our specific populations and individual patients. And there are a couple of rules of thumb. First, I think we have to realize that the literature we read is not necessarily in our population and is infrequently done in a population that has much higher risk or is sicker than the population we're going to consider treating. And so the risk distribution is skewed, and the patients in the trials clearly have more risk and therefore more potential for benefit than perhaps the average patient you're caring for in your NICU. The other issue, of course, is that if in fact the impact of the result is a constant in the relative risk reduction, that will be more and more meaningful in the patients with higher baseline risks. So let's see how some of those principles apply to the patients and the decisions we make. The first principle was that patients enrolled in clinical trials have greater baseline risks of the outcomes of interest. And a good example of this is the issue of the use of prophylactic systemic antifungal agents to prevent mortality and morbidity in very preterm infants. If we look at the Cochrane Review, there are 15 eligible trials, but 10 which specifically compare systemic antifungal prophylaxis to placebo or no drug. And here's the forest plot looking at the risk of fungal infection in these 10 trials of prophylaxis. You can see that they are varying sizes. You can see that some of the individual trials reported a decrease in the risk of fungal sepsis. But more importantly, you see a very precise estimate of the effect in that diamond there, the typical estimate, which tells us that there is a typical relative risk of 0.43 and a relatively narrow confidence interval for data that we look at, ranging from 0.31 to 0.59. If we translate that into more clinical terms and look at the risk difference, the point estimate for the risk difference is a 9% decrease in the absolute risk of fungal sepsis, which could be as much as a 12% decrease or as little as a 6% increase. From the studies, this suggests that if we treated 11 babies with prophylactic fungal agents, we would see one less case of fungal sepsis. But I draw your attention to the baseline risks in the control group. They are far greater than the baseline risks that we see in the general population that we're treating, making policy and recommendations in. The baseline risk here is 97 over 619, so something around 1 in 7 risk of fungal sepsis. Because of this, the authors conclude that these results should be interpreted with caution, since the incidence of invasive fungal infection is very high in this control group. In fact, if we look at Vermont-Oxford Network data, the mean rate of fungal sepsis is well below 3% for the past 5 to 6 years. And if we look even closer and break it down by gestational age, we see, though, that the means are meaningful, perhaps, in the most immature babies, ranging from 1.9% in babies 24 to 26 weeks to around 4% in babies less than 24 weeks. In fact, this is highly skewed data. If we look at the quartiles, we see that at 75% of the hospitals submitting data to Vaughan, there is no fungal sepsis. And I promise you that no policy of instituting systemic antifungal agents will take you and improve on a 0 rate of sepsis. That said, when we recently looked at our work from antibiotic stewardship, we see a significant number of infants being reported as receiving prophylactic antifungal therapy. We see close to 11 to 12% of the infants in the audit who are receiving this therapy, which seems like a very high number given for most of us, this is a very low risk. Many people have come back to me and said, okay, fine, I get that 75% of the hospitals don't see it, but my hospital does see it, and therefore it is a problem for me. I understand that, and in fact accept the fact that you might consider a policy of systemic antifungal agents. But I would also argue that there are a variety of other practices that may contribute to that, which either should be looked at first or in conjunction with such a policy. So for example, decreasing the use of broad-spectrum antibiotics, as Jiva spoke to us earlier, not using cephalosporins, and not using H2 blockers might all decrease the risk of fungal sepsis. So let's move on to some of the other principles involved in the decisions we make about whether we're going to treat a population of infants or not. And in this case, we'll take a look at the change in the baseline risk. You heard earlier from Brett about the results of the systemic steroid trials, either used early in the first week of life or later. And know that it is one of the most powerful therapies we have in treating and preventing chronic lung disease. Here from the meta-analysis of Lex Doyle's, updated recently in 2017, we see that there is a significant decrease in chronic lung disease, classically measured at 28 days, but more importantly measured at 36 weeks postmenstrual age, and in fact in the combined outcome of death or chronic lung disease at 36 weeks, also a very substantial reduction in risk. That said, we know that there are short-term concerns with the use of steroids, including hypertension and GI hemorrhage. In a similar fashion, later steroids in a more selected population have an even greater impact on improvement in chronic lung disease, either at 28 days or 36 weeks, as well as death or chronic lung disease. Clearly, what we all worry about are the longer-term risks that are reported certainly in the early studies of cerebral palsy and developmental delay. There is less evidence in the later studies suggesting that this population might in fact accrue more benefit than risk. We all know the very strong statements that came out both in the US and Canada regarding the use of corticosteroids, and the fact that they argue that it really should be very far from our routine, almost never used except in life-saving situations or in the context of research. So we know that after these trials and after these results, the neonatal community took up this evidence and acted. Almost 30% of very low birth rate infants were getting postnatal steroids in the late 1990s, and that has dropped to around 8 or 9% in the 21st century. But the question remains, is this the right 8 or 9%? And we're not totally sure of that. You heard Brett quoting Lex's work on a meta-regression, suggesting that, in fact, the greater the risk of the disease, chronic lung disease, which carries with it significant repercussions in terms of developmental outcome, the more benefit you accrue from starting steroids. But we don't know what that sweet spot is, and we have to think about it, and certainly this would be amenable to future trials.